Hi, I'm Vanessa May. This presentation I've been asked to talk about pelvic organ prolapse and pessary management. So I am based as a staff nurse at Greenlane Clinical Centre, working in the urogynecology department. My contact details and emails are there specifically so that you can contact me if you have any questions in regards to anything that's discussed in this presentation or in general about urogynecology, pessaries, or anything in that field. Discussing the symptoms of prolapse first. Most commonly, the ones that patients present with are those of mild to moderate degrees of prolapse, where they come with things like lower back pain, the feeling of pelvic pressure or heaviness, or dragging within the pelvis. They might have difficulty controlling the flow of urine or have symptoms of urinary urgency. These are common symptoms that present as kind of being okay to deal with, but that do develop into more issues around quality of life, that they feel they're not really participating in the same way because they know that at the end of the day they're going to feel more uncomfortable if they go for that walk with their friends, or they know that they're going to feel that they can't quite control their bladder if they stay out all day or go out to a cafe as a special occasion. So we do find that those symptoms, even though they are the mild to moderate, do still have quite a significant impact on patients' quality of life. Moving to the more moderate to severe symptoms, we do see patients who present with either new or long-standing issues with urinary retention, recurrent UTIs or urinary tract infections, and also we see a higher incidence of urinary stress incontinence in patients with a moderate to severe prolapse. We do find patients have issues with incomplete defecation or incomplete emptying of the bladder or rectum, and also those of feeling a bulge or a lump in the vagina. People describe it as feeling like they're sitting on a ball or an egg, or that they can feel there's something between their legs. These symptoms of prolapse obviously cause more of a noticeable impact on patients' quality of life, and we can see particularly when they are developing signs of, for example, a procedure or severe prolapse, when they are unable to go out and fulfill their normal activities of daily living because of this prolapse issue in their life. We find patients sometimes have had these symptoms for a number of years before they seek medical attention or bring it to the attention of their medical practitioner. Often it comes as a finding when they're having their smear taken. The smear taker might notice some signs of prolapse. It's often pointed out once women have the freedom of having their children have moved out of home, they might not have a full-time job when they retire, so they therefore have more time and energy to focus on their own health and well-being. And we do see a significant spike in patients who are over that 65-year-old mark, predominantly because life has got in the way rather than because that's when their symptoms have actually started. Discussing here those grades of prolapse, we can see at the top of the pelvic diagram here we have the normal position of the uterus and other pelvic organs there. A first degree prolapse is when we see that movement of the uterus to a more upright position, and that descent coming down in the second degree prolapse, and the third degree prolapse or procedentia, where you can see the cervix and part of the uterus are actually protruding out of the vaginal entrance. We also see these degrees of prolapse for either an anterior prolapse, where we develop a cystocele, and that's when the bladder wall is coming through and into the vagina and putting that pressure there, which can also cause that ballooning of that anterior tissue in the vagina. That can present with symptoms such as incomplete emptying of the bladder, issues with urinary incontinence, etc. We see at this stage also the rectal or rectocele prolapse, where we have the posterior compartment is prolapsing into the vagina. That ballooning of the posterior tissue can also cause discomfort, that feeling of incomplete defecation, and potentially feeling that there is that wee pocket or bubble of feces which is never quite expelled. Some women at this stage do have to splint or put fingers into the vagina in order to be able to pass a bowel motion successfully. This can be caused more by long-standing issues of constipation, as well as having common symptoms like diverticulitis, which increase the pelvic and vaginal pressures. Again, looking into these diagrams of those degrees of prolapse, you can see as the cervix is protruding out of the vagina in the clinical appearance of a procedentia. You can see how that procedentia is pulling all of those vaginal organs right down outside the vagina. Also pulling down things like the bladder wall, which can lead to that incomplete emptying of the bladder and increased urinary tract infections, based on the fact that you have that pool of urine which is never quite able to be expelled. Patients have to change position to be able to pass urine correctly, and find that when they stand up, they often have leakage at that point because the bladder is pushed into a position which it allows it to empty when they change position there. This diagram also helps to understand where patients have that feeling of dragging and heaviness, is essentially you can see that in that last picture where all of the organs are just dragging downwards and causing that pressure and that feeling of heaviness there. So looking at some risk factors for prolapse, a lot of patients come to clinic being diagnosed or having thought that they have a prolapse, and their first question commonly is around what has made this happen, what has caused this to occur, whose fault is it? In regards to what they can do about it, that usually comes as a second question from what has occurred to make this happen to them. So some common questions and answers that we have, we look at some factors that may have had an impact on their prolapse. Quite often there is not a single cause for their prolapse, but there are some identifiable risk factors that we can suggest may have had an impact on that diagnosis. So things like childbirth, particularly prolonged labour, large babies or traumatic vaginal delivery, commonly that vaginal delivery that has required an intervention such as a ventouse delivery or a forceps delivery, that is certainly a common risk factor that we see, and a lot of patients do present with prolapse after deliveries such as those. We also see those patients who have worked with heavy lifting or hard work where they have done significant pressure on the pelvic floor at all times, so standing for a long period of time, working long hours where they're unable to be sitting down. Also heavy lifting such as packing or fruit picking where they're carrying significant loads. We would be able to identify that carrying anything heavier than 15 kilos will certainly put a significant amount of pressure on the pelvic floor, and doing that for a sustained period of time will certainly contribute to a weakened pelvic floor and therefore a pelvic floor dysfunction such as a prolapse. Age I've put here as a risk factor. Being postmenopausal certainly does not aid in the prevention of a prolapse. We certainly see that more women coming through are postmenopausal age. As I've mentioned before, some of that is more due to lifestyle factors, but we also know as you go through menopause, your estrogen levels are dropping when the ovaries aren't producing that hormone as much. That drop in estrogen causes a generalized weakness in the tissue that can mean that the amount of flexibility and stretch that is there is not present after menopause. So a lot of women present with vaginal dryness, vaginal pain at this stage, and they may also present with feelings of pain or discomfort during sexual intercourse or a numbness during sexual intercourse. And again, that's due to the estrogenization of those vaginal tissues and how much flexibility and blood supply they have. So looking from a historical perspective, the use of a pessary for management of vaginal prolapse or pelvic organ prolapse has been around for a significant amount of time. If we look back to those risk factors that we've discussed for a prolapse, those factors of childbirth and heavy labour have certainly been in place for centuries for women, and therefore interesting ideas for management have also been in place for a long time. We've seen evidence of papyrus scrolls from 2000 BC where the discussion of treatment for prolapse has been mentioned. A lot of these methods at this early stage did involve, for example, getting the patient to stand over various burning objects and having the smoke encourage the pelvic organs back into the pelvis. There is, however, limited evidence to see if this was successful in most cases. We can also see evidence Hippocrates has advocated the tip and shake method, one of my favorites, where you gently pick the patient up, turn them upside down, and give them a good shake. This is the way to be encouraging those pelvic organs back into place where they need to be. We also see another Greek physician has documented prescribing a pomegranate shell for the use in prolapse, which seems much more practical, putting a pessary or a pomegranate shell in place into the vagina to be able to actually push those pelvic organs back up to where they need to be. As well as the pomegranate, there's also some rather uncomfortable looking devices from about the 1960s and 1970s, right the way up until the 1980s, where physicians were using metal pessaries or a ring-shaped device that was placed inside the vagina to hold up the pelvic organs when there was evidence of pelvic floor dysfunction. You can see in the advertisement here, the Hastings and Macintosh Trust was developed with the cup-like device at the bottom there that was inserted into the vagina to push the pelvic organs back into place. And this device was worn kind of like underwear inside and aimed to be providing more comfort for women so that they could continue their activities of daily life. We look again at that history there. The word pessary actually comes from the word pessos in Greek, which is an oval stone that was used to play checkers. So it certainly had some very innovative ideas used for this management of prolapse for centuries before we have come to try. It took until around about the 16th century for us to have first purpose-made devices for the management of prolapse there. These tactics to be able to manage prolapse certainly seem eye-opening and eye-watering at this stage. However, we can identify that the fact that these ideas were created and these devices were used is based on the fact that prolapse and pelvic organ dysfunction has been around for a very, very long time, and we're therefore able to identify that every day we're able to improve our practice, and therefore we're able to improve the care that we give women who have issues like pelvic organ prolapse. We've certainly come a long way from burning various objects underneath women to encourage those organs to retreat. And I think the modern pessary that we use today is significantly innovative to be able to create more comfortable prolapse management for our patients. So some looks at the modern pessary today. The brand predominantly that I use is that of Milex pessary. However, there is a varying range of pessaries available both in the community and within a DHB setting. These pessaries are made of hospital-grade silicone. The recommendations are that they be changed or a new one placed after 5 to 10 years, depending on the degradation of the material. We see there on the left-hand side a cube pessary. Looks like the fluffy dice that you have in your car. This pessary is predominantly used for younger women who are exercising or returning to an exercise regime, most commonly after childbirth. We do a significant amount of patient education for this pessary, as it's really important that patients can monitor this themselves. They need to be able to insert and remove this pessary independently. The current recommendations are that this pessary is removed at least once a week to have a clean and a wash. This pessary can be really useful to hold up the front, back and sides of the vagina, for want of a better term, to allow for that all-round support when they're returning to exercise and the pelvic floor structure is quite weakened. Obviously, because it is an occlusive pessary, this cube pessary, along with the donut pessary in the middle and the gel horn with the knob on, looks like a mushroom, that is also an occlusive pessary. So sexual intercourse is not possible when these pessaries are in place. We therefore need to look at educating patients to be able to remove these independently so that we're not impacting on their quality of life and functioning. Further down, we can see a Schatz pessary that looks like a discus. That is a harder Milex material and is quite good to hold up more complex or difficult prolapses where a plain ring pessary has been unsuccessful or has fallen out. Down the bottom there, we can see an incontinence dish with pessary knob, and these pessaries are used commonly in patients who also have issues with incontinence. The knob you can see there is placed to sit underneath the urethra, so it gives that urethra more support so that when pressure is placed on it, it isn't so movable. These can be used if you can identify a patient who has a urethra seal or more of a very anterior prolapse there. The plain ring down the bottom left-hand corner is the most commonly used pessary, and we use that for about 65 to 70% of our patients. The size ranges on that note also range from 55 millimeters right the way up to 114 millimeters. And that's really to accommodate the change in vaginal shape that we can see. A lot of women present, again, we're looking at that 50% of patients sitting between 57 and 80 millimeters. That refers to the diameter of the pessary, and again, we can use that to measure the vaginal length as how we decide which size. And I'll mention that slightly further on when we're talking about the size and shape of the pessary that we would choose. So when I see a patient for an initial assessment or a trial of a new type of pessary, the first thing that we need to do is a vaginal examination to determine the size and the severity of the prolapse that they have. Essentially, we need to look at what's going where and when, so that we can identify how we can best fit a pessary that will support their lifestyle, as well as containing and managing the prolapse symptoms that they have. It's important, therefore, that we discuss with the patient the preference they have for the type of pessary. It may be that they are not wanting to be sexually active, and therefore an occlusive pessary is suitable for them. We also might find that they have friends in antenatal class or cousins or sisters who have a certain type of pessary, and therefore that can influence their decision when they're choosing which type of pessary they would like. This kind of input from the patient is very important in providing patient-centered care so that we can allow them to be part of the collaborative plan that we're developing for their management. We do part of the vaginal examination as a digital examination to measure the size and length of the pessary. The other examinations that we do include a speculum examination to assess the vaginal tissues. Again, we're looking at things like atrophy and or any presence of ulceration or irritation. It's important at this stage to do a bimanual examination, again, by a trained professional, so that you can assess the pelvic structure of the patient. For example, issues like levator avulsion and or ovarian cysts or fibroids can always influence the decision in the pessary that you're going to choose. Patients who have significant fibroids may need a pessary in the interim while their fibroids are being assessed or managed, as they are the factor that's putting a significant weight of pressure on the pelvic organs. At this stage, we may choose to insert a pessary. We always do this with the consent of the patient and show the patient the pessary before putting it inside them. This is a very important step as it's influential in their decision to continue with the pessary management. If they know what's happening to them and they have that information, they are significantly more likely to continue with the pessary as management of their pelvic organ prolapse. After we've inserted the pessary, we then have the patient walk around, do a bit of a dance, bear down, do some coughs, a Valsalva, and again we're checking for movement of the pessary and or if the pessary is actually expelled. Sometimes if there is significant movement of the pessary, we may change to a slightly larger size, we may change to a different shape if that is expelled, so that we can really troubleshoot these issues at their first initial appointment. We encourage the patient at this stage as well to self-examine with their fingers so that they can actually feel where the pessary is sitting and know that it's in the correct position. There's nothing worse than when a patient goes home, feels it for themselves when they're in the comfort of their own home, and then feels unsure about what has been placed and where it is sitting within their pelvic structure. By getting the patient to mobilize and move around, we can minimize the chances that the pessary will be expelled later on. However, this presents as the most common issue or problem that we have with the pessary, in the fact that we can never fully assess exactly what type of pessary will fit, and we can never fully be certain that this pessary will stay in place. Encouraging patients to try it out. They have our clinic contact number so that if the pessary does fall out, they can always give us a call and we can see them again to try a different size. I've been told that fitting a pessary is much more of an art than it is a science, and I agree with this in that a lot of it is trial and error to try and get the right size and the right shape that works for that patient. And it's often a few different types or sizes of pessaries that we try before we come to the conclusion of the right one. This rather complicated looking diagram explains that choice process that we go through when we're choosing which type or size of pessary we think might be the best fit for our patient. When we're looking at a plain ring for first or second degree prolapse, that would be our first choice as a basic to get an idea of what will help this patient. At a GP level practice, this would be a great start to have patients who have tried a pessary and tried a size and worked out what doesn't suit them and their lifestyle. You can see that for a patient presenting with a rectocele, we do have limited options in being able to provide support for that. And we often find that patients who do have a rectocele with that history of constipation can also find that a pessary is hard to retain because of that increased pelvic pressure. So commonly when they are pushing for a bowel motion to be passed, they are actually pushing that pessary out at the same time. In patients who present like this, I commonly ask them to keep splinting, so to hold on to the pessary inside the vagina at the same time as they're bearing down to be able to pass this bowel motion. This works. If it doesn't and the pessary is expelled, again, having that education and knowing that they can put the pessary back in themselves can be very empowering, so that they know they don't have to panic. They just need to put the pessary back in and everything will return to where it's meant to be. Again, encouraging the management of constipation can be very important. So going back to that initial appointment, discussing things like lifestyle changes, dietary modifications, increasing fluid intake, and really closely monitoring that they have soft, easy to pass bowel motions can reduce the chances of the rectocele becoming more of an issue and the pessary failing to be able to manage that rectocele posterior prolapse. With a cystocele, you can see there are a lot of options for us to use, and therefore we have a lot of backup plans. Quite often we would be going to plan C by the time we actually get a pessary that will work and be functional for the patient. These patients, although they have the easiest to manage prolapse with a pessary, can still be subject to a few issues or troubleshooting road bumps that we need to navigate with them. You can see again from this diagram the significant range of size and shapes that we have available so that we can use this range to really provide the best pessary for that patient. Follow-up care is obviously a significant and important issue to discuss. And again, I bring this up at the initial appointment so that they can feel they have that security of knowing when their follow-up will be, how this pessary will be managed long-term. We do 6 to 12 monthly appointments in my clinic. At this appointment, we would be removing and cleaning the pessary. To clean a pessary, you're just washing it with warm soapy water. So when patients are doing this independently, I often tell them to do this removal and insertion in the shower where they have water running, they have clean hands, they don't need to have sterile equipment. The vagina is not a sterile space. And they can very easily put the pessary back in with that water as natural lubricant to be able to do that easier. At this follow-up appointment, we also do a vaginal examination, again with a speculum, and this is really to evaluate the health of the vaginal tissues, again looking at that vaginal atrophy and making sure that there are no signs of irritation or ulceration caused by the pessary. We then put the pessary back in, all being well, and continue this follow-up indefinitely if need be. Of note, when we do the vaginal examination, if we note any issues such as discharge or ulceration, we would then clarify with the patient exactly what the care plan would be for that. Some possible predictors of pessary failure I've mentioned briefly, these main ones being having a short vaginal length, either from a previous surgery or just a vaginal stricture due to atrophy and aging. Previous hysterectomy patients can be quite difficult to fit a pessary for due to this change in vaginal shape. Most commonly, women who haven't had surgery have more of an oval or diamond-shaped vaginal vault. Those who have had a hysterectomy have more of a cube or rectangle-shaped vaginal structure, which makes it more difficult to fit a pessary in place. But again, there are some more ovoid type shaped pessaries that can be more suitable for these patients. Patients who also have a wide introitus can be quite difficult. This is predominantly because there is no structure in place to keep the pessary where it needs to be. A wide introitus can be again caused by that traumatic vaginal delivery, the use of interventions such as ventouse or forceps that cause a more gaping vaginal entrance. This can sometimes be improved if we use something like a cube or a donut as a temporary measure, and actually encouraging the use of physiotherapy exercises with a pessary in place has been shown to increase the pelvic floor strength by up to 25%. This use of physiotherapy and pelvic floor exercises is very important even with a pessary in place, as we know that it encourages those muscles to regain that muscle memory and therefore be able to hold the pelvic organs in place. After they've been using a cube or a donut pessary for a number of months in conjunction with physiotherapy, we may then be able to look at trying a more simple ring pessary or ring pessary with support that will give them more of a easy way to manage their pelvic organ prolapse. We can also see issues, as I've mentioned, with posterior wall defects, so a rectocele or a significant posterior prolapse, where that posterior wall is causing a significant bulge that's exacerbated by ongoing issues of constipation. It can be that a pessary is just not able to be retained and the patient is not able to independently remove or insert the pessary themselves. Levator avulsion is another issue for pessary management. We find patients who have had levator avulsion where that levator muscle has been torn during a vaginal delivery. We find that those patients are often unable to retain a pessary, or that the pessary sits on a funny angle because of those muscles not being evenly positioned within the pelvis. We also have a group of patients who try a pessary, maybe 1 or 2 sizes, and decide that a pessary is just not for them for whatever reason. And for that reason, they're desiring surgery or a surgical solution for their pelvic organ prolapse. These patients often have tried a number of methods or waited a number of years for management of their prolapse and find that the pessary is not a suitable management option for them. Culturally, it can be difficult having a foreign object inserted into the vagina that stays there long term. There can be issues, again, around female hygiene that is not suitable to be having a pessary or management of the same. Some patients, again, have friends or sisters or cousin, sister's friend that have had a pessary and haven't been successful, and therefore they're slightly biased towards what they would require, and therefore a pessary is more likely to fail if they're really wanting to have surgery. Some find a pessary as a stepping stone. So the 3 major conservative methods for management of a prolapse are that of expectant management, so waiting to see what happens or when it gets worse. Physiotherapy, so doing physiotherapy exercises to try and improve that pelvic floor function, and the pessary is the third. Often patients have tried all 3 of these options and then get to the 4th option of surgery as a more definitive measure of managing their pelvic organ prolapse. Biased as I am towards pessaries and how amazing they can be and how life-changing they can be, I do acknowledge that there are some common problems and issues with pessary use, and a number of women present with these problems and do need a clear pathway of management and navigation of these. A lot of women have an increase in vaginal discharge when they have a pessary in place. This can be due to stimulation of the cervix. For example, when a pessary is that of a ring with support, we find that that diaphragm does denote cervical excitation, which causes an increase in mucosal discharge. This normal physiological vaginal discharge can build up within that support diaphragm and therefore be bothersome for the patient. Again, a common complaint is that of an odor. This is either from incontinence that's caused by the prolapse and or from the increased vaginal discharge that does occasionally have an odor to it. Discussing with the patient what their normal vaginal mucus can look like can often be an interesting conversation, and working out if this odor and discharge is actually different from their normal, and or if it's an increased vaginal discharge that is really bothersome for them, if they're having to wear pads every day for this discharge. This can often be a conversation to have. If this discharge is more of a problem than your prolapse is, then the pessary is not really for you. It's not really working, and it's not doing what we want it to be doing. Obviously, the issues we have with ulceration and vaginal irritation can be a major issue when we're looking at the management of a pelvic organ prolapse with a pessary. We don't want to be causing more harm, so we need to be balancing the risk of ulceration and irritation, with the potential benefit of having the pessary in place. Ulceration and irritation can prove to be quite a serious issue if they're causing an irritation or ulceration that is deep enough to cause a fistula. Again, this will obviously result in a surgical procedure needing to be completed, as well as significant consequences for the outcomes of the patients. Some patients find that having a pessary in place causes significant pelvic discomfort. This can again be described as a short-term issue when a pessary is first placed. Quite commonly, the pelvic organs, because they have been down and have been dragged down for a significant amount of time, when a pessary is placed, they are unceremoniously shoved back to where they're meant to be, and this can cause quite a lot of pelvic pain. This pain, although it can be moderate to severe, should be really easing within 1 to 2 days and shouldn't require anything stronger than paracetamol or ibuprofen. If women present with more pelvic discomfort that is ongoing and is not relieved by analgesia, the removal of the pessary is seriously indicated. Again, I find at this stage, if you have provided patient education on how to independently remove the pessary, they're able to fix this themselves, and or they can be encouraged to do this over the phone to allay their fears of ongoing pain. An issue that does arise occasionally is that of incarceration. This is when scar or granulation tissue forms around the pessary as that skin from an ulcer or irritation is trying to heal. This scar or granulation tissue brings a ring around the ring, which therefore needs to be removed. Most often, this can be done with a small surgical procedure in the clinic room, where the pessary is the one that we cut. We then are able to bring that ring around through that band of tissue and able to drastically improve the situation quite quickly. This does cause occasional vaginal bleeding, which needs to be monitored. But again, we're able to replace the pessary relatively quickly within 2 to 4 weeks after this incarceration. Occasionally at this stage, we do see a change in size of the pessary, because essentially the sides and the walls of the vagina have stuck together to granulate and try to heal. This means that the vagina may be slightly shorter in length, and you therefore require a slightly smaller size or a different shape of pessary to provide the same level of prolapse support. It's important to note, however, down the bottom there, that complications are rare in the properly fitted and well-maintained pessary. And this is something that I try to encourage my patients to remember, that although these complications do happen, we do have a backup plan of treatment, and they are very rare. When we know what we're doing, we know how the pessary is being fitted, and we're monitoring it so closely to ensure that these complications don't happen and don't cause any significant outcomes. Most common postmenopausal risk we find is that after menopause, because of that drop in estrogen levels, we have fragile, thin vaginal tissues. This causes a high risk of ulceration and irritation, as well as bothersome symptoms such as vaginal dryness, which can cause discomfort during sex. The main fix for this is Ovestin cream. And Ovestin cream is prescribed 3 times a week at night, with a pea-sized amount being put on the finger. It does come with a plastic applicator. I commonly encourage patients to use a finger, as this is less invasive and more comfortable for the patient. By putting the estrogen cream in last thing at night, it's able to be dispersed throughout the vagina overnight and therefore reach most of the surfaces within that vaginal tissue. The estrogen is absorbed locally, not systemically, and studies haven't shown any rise in estrogen levels in patients who are using Ovestin cream. This is an important factor, as we know that patients with a hormone receptive breast cancer are unable to use Ovestin because of the estrogen levels. Usually on discussion with the medical oncologists, we can come to an agreement about the amount of Ovestin or the level of Ovestin that they're comfortable with using for a patient who has a pessary for ongoing prolapse management. On the diagram here, you can see the thin, fragile, atrophic vaginal mucosa of a postmenopausal patient. And you can see then the increased risk of irritation and ulceration that we have if we're putting a pessary in place that is going to rub on those tissues. You can see on the left-hand side the healthy vaginal mucosa there, which is thick and bouncy and well vascularized and is therefore able to cope with having a pessary in place. Ovestin cream in and of itself can be a significant impact on improving their quality of life as it improves the discomfort that they have for sexual intercourse, and it can be known to improve issues like urinary incontinence because it's increasing the flexibility and rigidity of the muscles around the urethra. So for your information, intercourse is definitely possible with pessaries that are not vaginally inclusive, like those that I've described, the gel horn and the cube pessary. The most commonly asked question, however, it's often not asked until the end of the consultation, quite sheepishly, is that of if they can still have sex when they have the pessary in place. So to ease patients' discomfort, I often bring this up first when I'm talking about the pessary and say it doesn't impact on being able to have sex. You can continue that activity as you have been doing. The pessary might get in the way. We can teach you how to take it in and out yourself, no worries. When you're teaching patients to be able to take a pessary in and out themselves, it's really important that they have the dexterity and the know-how to be able to insert the pessary and remove it as necessary. Patients with significant arthritis, for example, or issues with cognitive decline such as dementia are not going to be suitable to be able to independently manage their pessary. Again, in some contexts, it is not culturally appropriate for a woman to be examining herself in order to be able to take the pessary in and out. As well, there are age taboos around the level of intimacy that you can have with yourself, and therefore your familiarity with your own anatomy can be decreased. In the older age group, it's never been discussed or a subject that they have found themselves comfortable with, and therefore the idea of managing the pessary independently is quite confronting for them. I've put at the bottom there a note to always ask about sexual activity and never assume. You don't know what's going on behind their closed doors, and I have a significant amount of 80-year-old patients who would put a lot of us to shame and make us blush. Just because patients are postmenopausal or over a certain age does not mean that they are no longer sexually active. In some cases, they're a lot more sexually active than they were in their younger years. In this way, it's really important that we acknowledge that as a significant part of their life and manage the pessary around that lifestyle choice. These patients present in a very shy way and are often quite nervous about asking for support around taking the pessary out so that they can have sex more comfortably. So giving them the resources and the comfort and understanding to be able to engage in those kind of conversations is really important as part of their care. So when you're teaching a patient to be able to independently insert and remove the pessary, it's really important that you get them to practice. I get patients to practice while they are in clinic. However, I do acknowledge that the sterile clinic environment is not the most relaxing place to be able to put a pessary in. And the more relaxed patients are when they're doing this procedure, the more comfortable it is for them. There is a knack to doing it, and certainly something that does improve with practice. The first time that they put the pessary in and the first time they take it out will no doubt be their hardest. Putting the pessary in place, they're able to fold it in half. The Milex pessaries that I use have a small hinge, which means that they can be folded in half like a taco and then placed inside the vagina in a similar position as you would to putting a tampon in place. By folding the pessary in half, pushing it into the vagina as far as you can, and then pushing it up that little bit further, you're able to ensure that the patient can get the pessary up to the highest level where it needs to be. The pessary sits just behind the pubic notch, so patients shouldn't really be able to feel it in place. If it's slipping down slightly, the common analogy I use is that of when you have a full tampon, you can feel it coming down slightly as it's irritating the nerves around the entrance to the vagina. The best solution for this is just by putting a finger inside the vagina and pushing it up slightly. It may be that patients need to do this a few times when they have an initial pessary fitting, as the pelvic structure is just getting used to having the pessary in place. There are some alternative positions to the right of being able to sit comfortably to have the pessary inserted. And again, I've mentioned doing this in the shower is a lot easier than trying to set up a clean area in the bathroom. When you're in the shower, you're much more likely to have 5 minutes of alone time where you can lock the door and not be interrupted. You're more likely to be clean and relaxed with the shower running, not having to wash again 50 times because you touch something else and have to clean your hands before you touch the pessary. By doing it in the shower, you're in a nice, relaxed environment, and you can then put the pessary in, give it a wash with warm soapy water, take it out, give it a clean, put it back in again with no stress or issues. To remove the pessary, again, being in that relaxed, comfortable environment is very important. You don't want the patient to be stressed or clenching and holding on when you're trying to remove a pessary, as this will cause significant discomfort and distress. To remove the pessary independently, a patient needs to put a finger inside the vagina to be able to feel the rim of the pessary. They then gently pull down on the pessary at the same time as coughing and pushing down, bearing down very hard. I encourage patients to keep coughing until they have the pessary right out in front of them, as it's very common to panic halfway when the pessary is in the middle of the introitus and causing the most discomfort. By panicking at this time, it means that the vaginal muscles constrict, and therefore they're holding on to it at the same time as trying to pull it out. This can be very painful for the patients. Again, encouraging them that the first few times will be their hardest and it will get easier is very important. A valid point to make is the difference that a pessary can make in women's lives. I certainly find a great deal of job satisfaction when I'm fitting pessaries, as I know that they can alleviate the symptoms of pelvic organ prolapse almost instantly. Women can walk into clinic with a significant prostodenture, have a pessary fitted that is correct and holds up their pelvic organ prolapse, and stand up from the clinic table feeling a completely new woman. A common phrase that I hear is, "I wish I'd come and seen you sooner." And this is something that's really meaningful for me, and that I know that a lot of patients out there could benefit from having a pessary earlier. They could benefit from a pessary in the antenatal period. They could benefit from having a pessary a lot sooner than when they come to seek medical care 20 years later. I find it sad that women have not been able to focus on their own health and well-being, but commonly patients have had the symptoms for 10 to 20 years before they come and seek medical attention. We're finding that there's a new wave of awareness for patients discussing pelvic organ prolapse and discussing issues like incontinence post-vaginal deliveries or post any kind of delivery. And this awareness and discussion of the subject is really important so that women know it is common. 1 in 3 women in New Zealand do have symptoms of pelvic organ prolapse, but they also know it's not okay and that there is something that we can do about it and something that we can fix the pelvic organ prolapse symptoms relatively quickly without having to have surgery. Being able to manage it conservatively is really, really important. We find that a pessary can have a really high impact on their quality of life. They can go out to the cafe with friends, they can go for walks, they can stay overnight visiting their new grandchildren. They can have freedom to participate in the activities of daily living that they haven't had for a long time, or that they haven't been able to fully participate in because they've been held back by these symptoms of pelvic organ prolapse. A pessary and a pessary fitting is a really important aspect of women's health practice, and something that we all need to be aware of when we're looking at women and caring for women as part of their navigation through the health system. Being with them on that journey to be able to participate and be able to provide that care is a very privileged position, and something that we need to acknowledge is a great part of our working practice. On saying that, we do not have any guidelines of practice or any research around practice in New Zealand for pessary care. There is limited international research around pessaries for pelvic organ prolapse management, and minimal to no research around those where it is a nurse-led clinic such as mine. This lack of guidelines and research makes it very difficult to practice at times. So I'm very lucky that I have a really dedicated urogynecology team that I can call on if I have any complex patients or issues to discuss around the best management for pelvic organ prolapse for my patients. The main take-home points of this presentation. Hopefully you've been listening the whole time, but if not, now's the time to take notes. Self-care can be individualized, and it needs to be individualized. This can be quite an overwhelming appointment when they first come for a fitting of their pessary. And so I feel that sometimes it's best taught at the second follow-up. Once the correct fit has been assessed, we can then discuss with them how to manage their pessary, how we plan to manage their pessary care ongoing, and how we can best tailor that to fit them and their lifestyle. It's important to give women reassurance that the pessary can't go anywhere else. And I know this feels like a silly question, but I have a lot of women who come to the clinic not having that familiarity around their own female anatomy and not knowing where everything goes and what's happening for them. So discussing with them, drawing a diagram, showing them an integrative model can be really important in educating them around what is happening to their body, and therefore how what we're doing will actually help them and benefit from them. We also know that when a patient has information, they're much less likely to have any ongoing issues, because knowledge is power. Encouraging the patient to practice, and that practice makes perfect. This is also relevant for the practitioner as well as for the patient. So the more pessaries you do, the more pessaries you interact with, the more patients with prolapse that you evaluate and talk with and discuss, these are going to make a difference to your practice. The number of times I've had patients say to me, how long have you been doing this? How experienced are you? It's really about how familiar you are with dealing with complex situations and how you know who to call if you're not feeling comfortable in managing that situation. Giving the patient information about the risk versus benefit of the pessary, when to call their GP, when to go to the emergency department, can be really empowering as well. We know that patients can panic when they're at home if they have any issues. It's important to talk to them about if the pessary falls out. That's okay. They're not going to be any worse than they were before they came for their clinic appointment. And it's really important to acknowledge that with them and go through the steps on how to rebook a clinic appointment so that they don't have to stress about it. We do want them, however, to be able to go to the emergency department if that situation arises. If they have an event where they're unable to pass urine because the pessary is causing retention or blocking the urethra, they need to go to the emergency department. If they're bleeding significantly because of the pessary, they need to go to the emergency department. If the pessary is causing significant pain and they're unable to move the pessary or remove it themselves, they need to go to the emergency department. Having that backup and knowing that that's what to do if things go wrong can be really empowering for women. They know, oh, it's not that bad. I can call the clinic in the morning and we can talk through what to do. Or they can identify, this is really serious, I need to get this fixed right now, and therefore feel confident and able to go to the emergency department when they need to. Although it is time consuming, I think it's very important to acknowledge that the more the patient knows about their pessary and their self-care, the more aware they are of their potential problems, They then become more confident in independently managing their own health. And again, then we can be part of their collaborative care to be able to be part of them navigating this health journey that they're on and able to provide efficient and good pessary management for their pelvic organ prolapse. I've included at the end here some useful links. I find these are really beneficial when looking at ongoing continued professional education, as well as education for pamphlets, so for patients around pamphlets that you can give them. The top one there, Cooper Surgical, goes through the Milex pessaries that I've mentioned. And you can see there the range that they have available for the different sizes and shapes of pessaries. The middle link, Your Pelvic Floor, has a great range of International Urogynecology Association leaflets. These leaflets range from the pessary for management of pelvic organ prolapse. They also cover surgical procedures such as an anterior repair, a posterior repair, repairs for stress incontinence, pelvic organ prolapse repairs, sacrospinous fixation, urodynamics, and a wealth of other issues or procedures that may come up in your conversations with patients around the issues with incontinence and or pessary use. There's a great leaflet there also about providing estrogenization for women who are postmenopausal by using things like Ovestin cream. Giving this to patients when you're prescribing Ovestin cream means that they're much more likely to be using it effectively, and as you prescribe it, with that understanding of how and why they're using it, they're much more likely to be compliant. The bottom one talks about resources for continence that you can use. It does mention there the pelvic organ function, as well as pessaries for management of pelvic organ dysfunction and prolapse. I really hope this talk has been beneficial for you and that you've learned something about pessaries for the management of pelvic organ prolapse. Feel free to contact me anytime. My mobile number and email are listed here so that you can ask me any tricky questions about patients with pessaries, any tricky questions about complex urogyne procedures that need to be done, or if you have any questions related to the material that I've covered in this presentation. Thank you so much for listening. Oh no, now it's recording.